Review Subcommittee on Justice and Judiciary for the 2023 interim. Today we're going to hear from the Justice and Public Safety Cabinet on substance abuse treatment programs. The current budget required both the annual report describing the funding and the programs administered by the Cabinet, as well as the external performance reviews of substance abuse programs, which there was $1 million appropriated for this purpose. So any meeting materials received by the deadline were posted online earlier in the week and made available for downloading, and I believe you'll be presenting that today on the big screen. Thank you for doing that. At this time, we'll have the Secretary call the roll.
Senator Nemes, Senator Schickel, Senator Webb, Representative Brown, Representative Decker, Representative Kulkarni, Representative Sharp,
Present.
Senator Mays-Bledsoe, Senator McDaniel, Representative Petrie, Representative Reed, Representative Elliott, Representative Flannery, present. Chair Funky Fromeyer.
Thank you. At this time, I think it'll be helpful with this great background noise, perfect setting. Let's hear from our guest today. And thank you again for coming, Van and TK. We'll look forward to hearing your presentation, and then we'll hold any questions until the end. So if you would, please introduce yourself and remember to press the green button.
Okay. Madam Chair, members of the committee, my name is Van Ingram. I'm Director of the Office of Drug Control Policy. I've been with that office since 2004. In the FY23 budget, as the chair indicated, the enacted budget includes a general fund in the amount of $1 million in FY23 to support external performance reviews of substance abuse treatment, prevention, and recovery programs administered by the Cabinet. Office of Drug Control Policy is required in statute to grant money to community mental health centers, as well as NAS treatment facilities, that is neonatal abstinence syndrome, facilities that provide residential services to pregnant and parenting women with an opioid use disorder. We are also further in statute required to provide funding to the Department of Corrections to provide treatment services in jails and prisons. There are already two evaluations that existed. The Kentucky Treatment Outcome Studies is an annual study that looks at community mental health centers. And the Criminal Justice Treatment Outcome Study, or CJKTOS, evaluates Department of Corrections, those criminal justice involved treatment programs. So with those two things in mind, we approached the Center for Drug and Alcohol Research at the University of Kentucky and asked them, with this $1 million, could they enhance the efforts that we're already doing to get a better profile? So for the amount of $297,492, they presented us with a proposal of what they could do to improve upon the two programs that already existed. And my friend from University of Kentucky, Center for Drug and Alcohol Research, TK Logan, is here to describe that process.
Good morning. Thank you for having us come. We're excited to be here to talk about all the hard work we did in about 6-month time period. Can you hear me?
Yep, you're on.
Okay. Also, I wanted to introduce the team. Since we worked so hard, they wanted to come as well. Dr. Michelle Staten, Dr. Jennifer Cole, and Casey Baker and Hope Tevis are here as well. So we know that substance use is continuing or actually increasing over time in Kentucky as well. But we also know that substance use disorder programs can and do make a big difference for people, helping people. And we know that in Kentucky. And I have evidence of that I'll show you because we do have these evaluation programs. So I'll show you that in a minute. But we also know that there are people who are still falling through the cracks. So we saw this funding as an opportunity to sort of better understand what are those barriers for some of those people to engaging in substance abuse treatment. One of the research has shown that it's most helpful. The longer you're in a program, the better you're going to do. So the threshold that's been identified is at least 3 months. But again, longer is better. There are studies that have suggested that from the first phone call to 30 days in treatment, about 80% of people drop out of that process. So these are just some things that we wanted to take as we went through in mind. And on top of that, when we look to see what barriers are in the literature, what we found is that many of those barriers focus on personal characteristics or individual characteristics. But what we really wanted to do is look at those barriers that were plausibly addressable through policy changes potentially, or maybe targeted funding. So with that in mind, our 3 objectives were to look at program performance indicators, and this also came from the language that was written in the budget. We tried to interpret what was being looked for, but these program indicators sort of help people understand how many people are being served, how long are people staying, quality of the programs. The second thing we wanted to do was understand staff barriers, because staff are the program. They are the most important resource when engaging consumers or clients in these programs. And so we have to figure out how to support them so they can best do their job. And then finally, we wanted to understand who has the unmet treatment needs, and then from voices of people who are being impacted. So people who thought about going to treatment but didn't, or people who had recently dropped out of treatment, what did they say their barriers are? So, as Van said, we had around $300,000. We did 4 projects in a 6-month time period. So this is all we basically did for 6 months. And we have 5 reports. So the first project we did, which was led by Jennifer Cole, was looking at what does the literature say those program performance indicators are that should be collected, looking at what Kentucky has to some extent. I'm not sure I understand fully everything Kentucky has, but we know some things. And then looking at overlap between the evaluations we have. And one of the things Dr. Cole did in this report for this particular project is profile each region, CMHC region, as well as the recovery centers in Kentucky and the DOC programs, using a variety of data to bring everything together. And I'll show you that. We did a big provider survey with a response of 833 staff that work in these programs, both the CMHCs, the recovery centers, and the DOC-related programs. We did the consumer survey project, and Michelle led this project. So we talked to 62 very in-depth interviews with consumers who either thought about treatment but did not enter. That was about 40%. And then those who had dropped out in the past year, that was about 60%. And then we did the Secret Shopper project and I led those 2, the provider survey and the Secret Shopper project. So we trained students to a scenario of a consumer, a substance use user who was trying to get into treatment. Half were pregnant and half were opioid users. And so we mixed things up. And then we just kind of had the callers document what happened, how it felt, that kind of thing. And then in that particular report, each region that we talked with, there's a profile there just kind of explaining what happened. And then we did a final overall, because nobody's going to read all of these pages for these 4 reports, that just kind of summarize what we did and then integrated the conclusions and recommendations. So most of what I'm going to say comes from that final report. We integrated everything into these 5 main questions, and I'll just go through each question. So why does that first phone call matter for program engagement? So that same study that said 80% of people drop out from that first phone call to within 30 days of treatment, 45% do not show up for that first appointment. So that's a first place that we're losing some people for some reason. And we feel like that might be one of the most important steps in engaging clients. And this is just what the profiles look like for each region. So we recommend standardizing a script and really training people about how important that first phone call is. And asking about scheduling preferences and providing information like where to go to the program, what to bring, and what to expect. We feel like that will help people better be prepared to show up to the program. And then to talk to consumers about the different program approaches. So some programs that you call, and I should say, I forgot to say this before, we also called 4 prenatal programs. But so some of the programs, when you call, they offer a variety of approaches. Other programs are more narrow. So but just talking to consumers about, again, that's part of what to expect. We also thought maybe this first phone call, because people are dropping out, what we want is, no matter what you do, there's probably still going to be people that don't show up, but hopefully they'll re-engage later and re-engage quicker, or take some of the resources that they need right then to support them so they can do better when they get, be more ready to engage in that program. So we thought that the first phone call might be an opportunity to quickly assess some risks, some key risks. Recent incarceration, because if they haven't used for a while, they might be more at risk for overdose. If they use, just talking to people quickly about overdose risk, suicidality, domestic violence, or other personal safety risks they might have going on in pregnancy. And you could share some quick information depending on their risks, where to obtain Narcan, or just educating them, asking if they have prenatal services, that kind of thing. And everything I'm saying is in that handout I gave you as well. I know I talk really fast, but and the second question is sort of what can programs do to make that recovery journey more successful for clients? And across all of the things that we looked at, all of the data we collected, these were kind of the 3 that stood out to us. One, clients often come into the programs with crucial resource needs, so financial needs, or if they go to treatment, how are they going to put food on the table if it interferes with their job? And or do they have child care, or do they have pet care while they're gone, things like that. So, and they're often isolated from their support network. So it's just really important to help them get that support for those basic resource needs or social support. And it really came out during our interviews how important these peer support workers are in providing support to clients as well. The other thing that sort of came out is just how restrictive some of these programs are, and then trying to think about allowing as much choice for clients as possible. So maybe it's a scheduling choice, maybe it's a harm reduction choice. Even if it's small, working within that program curriculum can help with motivation. And then addressing staff barriers, like I talked about before, making sure they have the tools to be able to do what they need to do, to spend those time and resources to focus on their clients. When we looked at who is at risk, and this is again across several of the data sets and several different questions, who have unmet treatment needs, we saw the things we already know that get said time and time again. So youth are particularly difficult. Women and postpartum, particularly pregnant and postpartum women, can be difficult to engage in treatment. People with co-occurring vulnerabilities, marginalized individuals. Individuals with limited personal resources, which I've already sort of talked about, they tend to do worse in programs. Individuals involved in the criminal justice system. The other interesting thing for me is that this older group, about 50 plus, I don't know where they're going to treatment. There's a small group that are coming into the CMHCs and the recovery centers. So I'm not sure where they're, and that actually came out as well, that both staff understand that that group is also not being served as well. I think the one that surprised me is the veterans, the persons on active duty, and their families were really brought up as well. So one of the things that really came out is that persons involved in the criminal justice system just have these unique risks. And these are, as you can see, even the people we talked to for our survey, those 62 people, high rates of incarceration, and in particularly recent incarceration. And so what happens is that people who are involved in the criminal justice system, like on supervision or certain programs, so they have additional requirements on top of treatment requirements, and those things sometimes don't always mesh super well, and it just creates a lot of juggling for the clients to do. And relapse, then, it's not necessarily the program policy, it might be the criminal justice system policies. And so those things just got brought up as being particularly difficult for these clients. There's increased stigma with that, and increased risk of relapse and overdose, potentially. But we also know, and again, I will show you these slides in a minute, how being engaged in those programs actually is associated with reductions in criminal justice involvement, which can save the state money. So when we looked at the program quality indicators, we know that they need to be feasible, reliable, and systematically collected. And the staff told us that their programs are tracking all kinds of information, a lot of information, but of those who said each indicator was collected, only about half said they had seen it or that it's transparent in any way. And we have no idea whether consumers are able to see this information or what information they're able to see. So you can see there's 5 main kind of clusters of these performance indicators. The last 2 we have, again, through our longitudinal evaluations of substance use disorder programs that we have. So we have some information about what clients think about these indicators and outcomes. What we do, though, is talk to them 6 months or 12 months, depending on each program, after they've entered the program. So there's always opportunity to collect more information as they're going through the program as well. So this is an example of what we have for the CMHC clients from 2017 to 2023. And you can see there's quite a drop. So around 42%, and it's pretty stable over time. Around 42% report any illicit drug use or problem alcohol use at intake or at follow-up, So that means 60% did not. Here is just what it looks like in terms of the people who are involved in the criminal justice system coming into the program, and then in the 12 months at follow-up. So any re-involvement dropped to 26%. This is for the recovery centers that we look at, and you can see, again, and this group of people, they target people who are homeless or transitioning out of jail or prison, and you have to live in the program for about 7.5 months. So their outcomes are much better because just being removed and supported, all those basic needs are supported, and then they live there for 7.5 months. So that's a long time for them to kind of get those skills built. And you can also see a big drop in criminal justice system involvement there as well. And then this is the substance abuse program clients in the criminal justice KTOS, and we see, again, a significant reduction in substance use, any use, and in the criminal justice system involvement at follow-up as well. This is just the profile that I was talking about that you can find in that first report for each CMHC. There's a ton of information that we gathered across all the different data sources we had for each CMHC. And then finally, our last question was sort of, well, where can the biggest policy or targeted funding changes make the most difference? And I really want to address here, because the theme that came up both with staff and with the consumers that we interviewed was a big barrier is motivation. And of course, yes, you have to be motivated to change. But if people are reaching out for the program, there's some motivation there. And I just want to talk, if they have program or systemic barriers, that can definitely impact motivation. So again, just supporting those, recognizing the potency of those systemic and program barriers, that to asking staff maybe to think about what could be these barriers instead of always thinking it's just the lack of motivation. Staff, media, all of us kind of need to think about how can we address those barriers to support that engagement. Again, supporting program and staff quality. So some of the biggest problems were lack of choice, not feeling valued or respected, feeling that there's some favoritism going on, and having some ways for clients to express that feedback or concerns during the program in a way that protects them. And another one that came out are just clients not taking the program seriously. And that's one we don't really have context for. That's something we would like to dive into more, maybe in a next study that we did or something. And then policies regarding that, the sanctions and termination. So a lot of what came up is like if there's one relapse, then they either get kicked out of the program or get sent back so far back. And it can just be really demotivating for people. But at the same time, then you have other people in the program who are working the program and not relapsing. So a way to kind of balance those things. But most of the people brought up that is a huge barrier just when you relapse, which is part of the journey of recovery. And if it sets you so far back, that can be a problem. So again, our main recommendations is really looking at that first phone call. How can we make that more supportive to increase that engagement? There's a piece of the barriers that we were not able to investigate in this 6-month period, and that is, all right, well, now the person has shown up for their appointment. What is the intake process like? What is the education process, and how does that work for clients? And just documenting those barriers is kind of another area. Capitalizing on that science of engagement and motivation, which is, again, autonomy, competence, and belonging. So just those three kind of things, which I've already sort of talked about. Making sure that clients and consumers can provide feedback, particularly for those specialized needs. So if you've got somebody who's marginalized or somebody who's having those unmet treatment needs and they're making program adaptations, talking with them about what would be helpful to them, what are their needs, and then how are these changes going. Investing time and resources for peer support workers. Again, such a valuable resource. Both the program staff talked about, the peer support workers help them in the program. They can relate to clients in a way they're unable to for a variety of reasons. And the consumers talking about how important these people were for supporting their recovery. But they need that we have to invest in them too, that training, education, supervision, and support, because we don't want them to get burned out either. Continuing that client feedback and outcomes so we can continue to track longitudinal outcomes. And then looking at those performance indicators and thinking about, is there something we can make more transparent? And then finally, just considering alternatives for when clients relapse. Questions? I don't know how long. Yeah.
Yes, Senator Schickel, please.
Thank you, Madam Chairman, and thank you for your presentation. I don't have any questions. I just have a comment, several comments, because I think I have a responsibility to my constituents and the people I represent to represent their point of view on this subject. So there's just a few things I'd like to say about it. First of all, I guess I basically disagree with the whole philosophy that you're coming to this problem with. My friend John Tilley, former Secretary of Justice, was the first person I ever heard use the term substance abuse disorder. the inference was that this is something like breast cancer or COVID or some other disease that somehow if treated properly, we can manage. But I'd like to remind the committee and the public watching that this is a subcommittee on judiciary, not health and welfare. This is a subcommittee on judiciary. And what was formerly called substance abuse, or which we now call substance abuse disorder, is a felony in the Commonwealth of Kentucky with certain drugs. Mere possession is a felony. And somehow that in judiciary that's been lost. And I know that you have a lot of statistics saying how well your programs work, but the reality of the matter is we're spending more money than we ever have had on treatment, and we have more a drug addiction than ever. We kind of have adopted the European model. Personally, I think it's a big mistake because at one time the Republican Party was the party of personal responsibility. And I don't see any personal responsibility entwined in the treatment model. Don't get me wrong, treatment has its place. But for someone to go to treatment after committing a felony without any consequences from the criminal justice system, and you act like contact with the criminal justice system is a bad thing for someone who has substance abuse disorder, I would say that if someone is committing a felony in the Commonwealth of Kentucky, they ought to have some contact with the criminal justice system before they go to treatment. And then maybe they will take what's going on seriously. Thank you for your indulgence, Madam Chairman.
Thank you, Senator Schickel. You definitely have a unique perspective to this, and I do appreciate your comments. Representative Flannery, Co-Chair Flannery.
Thank you. I have several questions, if I may be permitted to ask them. First question I have is, does the UK Center on Drug and Alcohol Research receive any private funding?
Well, the center is really big. I'm sure there is some private funding. It's made up of all kinds of people and all kinds of funding sources.
Okay, so maybe
I guess I would ask, what do you mean by private funding?
non-tax dollars, non-public monies.
Like pharmaceutical companies.
Could be.
Yeah, so some of our investigators definitely do. I do not, but yes, some do.
Okay. Do you know any of the private funding for the center?
I do not have, like it's the center, it seems like a cohesive, like under one building, but there are lots of people that are associated with that center. They're at all different locations, and there's a lot of work being done at all different kind of levels. So I was not prepared for that question. I could have gotten it, but I do not have it at my disposal.
Okay, thank you. Next question, part of, I believe it was number 4, discusses quality of a SUD program. As an attorney and someone who was an elected prosecutor and has been involved in the criminal justice system, I guess on multiple sides, I believe treatment can work. I'm not opposed to treatment. I've been an advocate for it, but I guess what I have learned from my observations and experiences that all the providers are not created equal.
Right.
There are some that do an excellent job and truly provide good care. There are others that are really bad actors in this space. And what's becoming, I guess, most offensive to me is, they are using tax dollars. They are being funded from Medicaid. And I don't have a problem with that if they're providing good quality care. But there are a lot of private providers that are not providing good quality care. And I think that's something we really need to take a look at. We've got a big debate on a certificate of need in the healthcare space. One thing that I've noticed in this particular space is that there doesn't seem to be any sort of certificate of needs for any sort of private addiction provider. Could you help me maybe understand a little bit more what one has to do to become a private provider for recovery medical services?
There are license requirements with the Cabinet for Health and Family Services to become a provider. And then there are credentials that have to be met from the managed care organizations to allow a provider to bill. But really the programs we're talking about today are the community mental health centers and the NAS programs that I'm confident in their abilities to deliver services.
Are the CMHCs, are they, I guess, kind of licensed just based upon their nature as a CMHC, or do they have to go through extra steps like a private provider would to receive a license?
Yes, they have to be certified as well and able to deliver substance use disorder services.
What, I guess there are certain recommendations that are listed in your all's presentation as to quality. What other currently what is looked at, whether it's a CMHC or whether it's a private provider, as to how do you measure success? How do you measure quality of services? What's currently being used to, regardless of whether it's a CMHC or a private provider, to try to figure out, hey, is this organization doing a good job in helping people that need treatment?
I'm really only qualified to talk about the programs that we're funding through Office of Drug Control Policy. I'm really not able to talk about programs that are funded through other sources.
Okay, so the ones that you're all funding, what's being looked at?
I have an employee that's a liaison to my office from the Cabinet for Health and Family Services, and she does site visits and monitoring of all the programs we fund.
Okay, thank you.
Representative Kulkarni.
Thank you, Madam Chair. I just have a couple of quick questions. Thank you all for your comprehensive presentation. I wanted to ask if you could quickly, and I apologize for coming in a few minutes late, summarize some of the results that you've seen. I know you had a few slides in terms of relapse rates, rates of return or incidences with the criminal justice system. If you could just quickly summarize the drops in those rates for us in terms of results from these types of programs.
So there are different ways to measure recovery, for one thing. And so what I brought today was really just looking at return to use, but we also use a multidimensional recovery index because return to use is sometimes part of the recovery journey. But for example, 40 to 50% do have return to use, but that means then 50 to 60% do not in our measures. Usually once people leave treatment, relapse occurs within that first 3 months after treatment, so we are capturing that. But if we went out longer, I don't know. So as I said before, Kentucky is helping. Our programs are helping a lot of people, but there are people that are falling through the cracks. I mean, this is any program. There are always strengths and there are always places for improvement. And I don't know that we've spent a whole lot of time on these programs looking for those places for improvement and working on those with maybe policy changes or targeted funding in a systematic way. I know at the individual program level or the CMHC level, I believe they take measures within their own program. And it varies. If you're serving more of a rural population, there's certain needs there that you might not see in a more urban population. So it's also at the program level. So it is really hard to kind of do it at that program level or at that microcosm, especially without more specific funding for the research. And a lot of the funding goes for the services, as it should. I don't know if that answers your question, but we do extensive reports every single year. We have the longitudinal data. We have feedback data from the clients. We have mental health data. We have victimization data. And we report that every single year, and it's out on our website for the public. We keep 2 years out. We also have fact sheets, so you don't have to read through the 150-page report. I mean, we work very, very hard to represent what data we're collecting and feed that back for everyone to see. So that stuff is out there for anyone who wants to see it.
Thank you. And to that point, in terms of populations falling through the cracks and not getting the care that they need, specifically, you know, you've listed here individuals with physical, developmental, learning disabilities. I'm specifically interested in those with developmental or learning disabilities who may not know or be able to consent to certain things or just know where to find these resources. That seems to me a very difficult population to reach and expensive and time consuming. So I wanted to just hear your comments.
So
on
again, I'm just reflecting what from the 833 staff that we surveyed, this is one of the themes that came up that is particularly challenging, and they feel like these are a group of people that we need extra eyes, brains on how to better serve. That all we're doing is kind of reflecting back that is an area that came up and documenting that barrier. I know we've always talked about co-occurring with mental health problems being challenging. I was a little surprised to see it's actually a little bit bigger than that. So this is a great opportunity that we've been able to document that and then give that to Van.
Yes, Representative Kulkarni, I've been in contact with Commissioner Marks with the Division of Behavioral Health and individuals with developmental and intellectual disabilities. We're going to put together a training for all the folks that receive this funding, probably several trainings on how to better do improve upon what we've been doing. I think TK has highlighted some things that we can do better at, and we're certainly going to try to do better at.
Okay, thank you. Thank you, Madam Chair.
Thank you. Were there any other questions? I'd like to pose a few myself. And thank you for this. And I often in committee meetings admit that I'm a new state senator. So barely 250 days on the job, but who's really counting? So recognizing, as Senator Schickel shared, we do have a criminal behavior behind those that are now coming for treatment and pursuing treatment. When I look at part of the objective that we were trying to achieve with the $1 million appropriated, as well, the external performance reviews of substance abuse programs, I'm unclear as to the array of programs available within Kentucky, and are there actual overlaps that were identified in this, or potential for coordination to achieve a better result? And I'm still unclear about what's the review. Do we have facilities rated a 1 and we have facilities rated a 10? And what's the difference of those facilities? I guess I was looking for a little bit more of a numerical ratings and actual summary of the programs.
This is not a Kentucky problem. This is a nationwide problem, is how to evaluate substance use disorder treatment programs. There's a lot of discussion and a lot of effort that's going into that. When much of the information is self-reported, it's really hard to tell how accurate it is. As far as like the community mental health centers, if you look into the reports, they have a scoring for a numerical score for each one. Is that correct?
Well, no, we haven't. I wouldn't know how you would score them. I mean, that's
on the calls.
On the calls, for sure. We had a rating of how overall the calls went, that kind of thing. Yeah.
I'll stop there and let you clarify. But I don't know of any system. I'm not aware of any system that says this treatment program is a 1 and this one's a 10. And I really don't know how you would do that.
I think that we do look at those performance indicators. That literature is all over the place. I mean, we have an extensive report where we reviewed that. And I think the next step would be if Kentucky's interested in pushing that further. I mean, one of our recommendations was that we have to get together with the key stakeholders to decide what performance indicators do we want to look at, how are we going to collect it in a systematic and reliable way, and then what are we going to do with it? Who's going to have access to this information? Is it going to be us, key stakeholders? Will it be consumers? There's nobody in the nation that we could see, and Jennifer, correct me if I'm wrong, but she's the one that spent almost 6 months diving into this terrible, terrible literature, state reports from other states and things like that, because we were looking for a map. We didn't find a map. I think that's okay. Kentucky can make their own map.
You remember an earlier slide of TK's that showed nationwide 80% of people drop out in the first few days of treatment. That makes it really hard to identify a good program from a not so good program when across the board people leave in that first week of treatment very, very often.
I'm recognizing that TK, you have some real clarity that you brought to some performance indicators that could be measured, but rather if we are measuring them, perhaps that's what you're recommending could be done, and perhaps we could then generate some results from that.
Yeah, so which indicators and what, for me, it's like what truly does represent quality on an average, because quality for one person, as we saw, doesn't mean quality for Van. I am a different person than Van. I have different needs. I have different addiction recovery journeys. So it gets hard. So I think the first step would be for some committee or group or person to sit down and say, these are the indicators we want, and then we'll have to just see. But like I said, we looked and looked and looked. Who in the nation is doing this? Who is tracking these? And there's some stuff out there, but we're still at the beginning of this. It's just really hard to quantify quality. And what does that mean? And again, we know that it's helping a lot of people because, and you saw those longitudinal trends are very stable. That's across studies, across programs, across time. So we know we're doing a pretty good job with a percent. The question is, can we improve on that? But that's at a state level, not at a program level.
Thank you, TK. And Representative Decker?
Thank you, Madam Chair. Thank you all for your presentation and for looking into these barriers. But I have kind of a comment instead of a question that is just a kind of contemplation of, I tend to get to this place in a lot of the hearings we have here in the legislature. Your very first comment under background led me to start thinking this way. You say that nationally there's a substance use has increased over decades despite the efforts to make it drop, and substance use disorders have increased over time. So then we hear, and I applaud you for looking at why is our treatment not working. But I would like for the legislature to also look at why are we here? Why are we increasing in substance use disorders? I've thought of this all throughout the summer at various hearings. We hear about behavioral health agencies and the need for more money for that because we are in behavioral health crises. We need more money for school mental health problems. We need more money for incarceration, for crime, for increasing crime, increasing drug use. And I keep wondering, what's behind all this? Why are we here? I keep hearing it during a hearing this summer. I got this vision in my mind. It's a bad analogy, but it's the best I can come up with, is that it's like we are standing outside of a house. All these different people are standing outside of a house, and water is flooding out of the house. And we're saying we need more buckets to catch this water. We just need more buckets to catch this water. And we don't ask, what is causing the water to leak out of the house? What is causing our children to have this mental health crisis? What is causing all of this? And I don't see us focusing on that. I applaud you for focusing on what is the problem that our services aren't effective? But I would like to see us, why are our families crumbling? What is going on that has not gone on before that is leading us to these? So that's just an observation I have in general about all of this. Thank you for your presentation.
Thank you, Representative Decker. In fact, you're articulating what I couldn't put into words. I believe that we're describing the water while we're drowning, and that's hard to sit here and just hear the description without a life raft. Representative Kulkarni? Okay, thank you.
I just want to say, I mean, that is the $1 million question, or by now $1 billion. I don't know. I mean, that is a good question. There are lots of people looking at that. There's no simple answer. I guess for me, the reason to focus on treatment is when people look for help, I want to say, are we doing a good job of helping them? When they reach that hand out, is there a hand there for them? And so that is where I really have focused my, these studies and that research. That question that you're asking is just, it's huge. There's so many different layers to that. Yeah.
There is a body of research, Representative Decker, that suggests adverse childhood experiences. When the more ACEs people go through as children, the higher likelihood they are of becoming having a substance use disorder. So things like food insecurity, violence in the home, difficult divorce, these kind of things are ACEs that we see in the history of people often who use substances.
I don't doubt that. And my question is, why are we increasing? Well, can we not learn and decrease? And I'm not meaning to imply at all you should not focus on these programs. I used to work for United States Senator Rand Paul, and he used to end almost every speech. It was never reported, but I heard it dozens of times, hundreds of times probably. He said, "We cannot look to the government to solve all our problems." He said, "We have a spiritual crisis in our country, and the things you just described are caused by a poor spirit. We need to have a spiritual revival. We need to figure out what is wrong with our spirit in America, what is causing all of this. We need to delve into that because we're spending, as you say, billions to treat the symptoms." Thank you.
Representative Sharp.
And thank you, Madam Chairman. I have a question kind of going along these lines. It's more of prevention. So my question is, how are things looking from the prevention side when we talk to kids? Because I think if we focus on getting into the schools and the kids, like the DARE program and that, has there been any studies on the effectiveness of the DARE program or other prevention programs?
There has been a lot of evaluation work with the DARE program. It's not as, my understanding is it's not as great as we would like. I think there are some benefits of the DARE program, like showing police officers can be good guys. They're okay to go to because sometimes a lot of kids are afraid. But in terms of prevention is very difficult to measure because you're measuring something you hope never happens. So it's a very difficult thing to measure. Some studies show some success, other studies don't. So also that's a whole other, and I don't know that we've done any recent
research? No.
On DARE, yeah. DARE's kind of, I don't even know how.
There's a program called Too Good for Drugs that currently we have in over 200 Kentucky schools that is evidence-based and researched. There's another program called Sources of Strength. That's another good research program that's evidence-based. Our state opioid response dollars we get from Washington pays for those curriculum for any school that wants them.
Okay, I'm a big believer in prevention, the ounce of prevention, pound of cure type of concept.
Yes, sir.
So I think we could put some money into that, maybe do some research and get it to where we want it, find a better way of doing this. Thank you. And I appreciate you guys being here. It's a very important subject. Thank you, Madam Chairman.
Thank you. Thank you for being here today.
Thank you, Madam Chair. Members.
That concludes what is our formal agenda. Is there any other concerns that we need to address? Oh, we do have, okay. I would like a motion to approve the minutes from our previous 2 meetings, I believe. Yes. And second by Senator Schickel. All in favor, we say aye. Okay, we are adjourned. Thank you.